Since the first aortic arch replacements performed during the 50s, this specialty has been steadily improving. Considered for a long time as a surgical challenge with major risks and uncertain results, it has become in 50 years an essential element of cardiovascular surgery, performed in many centers throughout the world with reproducible and reliable techniques and achievements. Nevertheless, the rules of aortic repair were totally changed in the early 90s when some surgeons, facing the incredible success of interventional cardiology and radiology, had the idea of treating the aortic diseases with endoprosthesis and stents. Many groups entered the fray and started to treat the aortic lesions using those techniques. Consequently, hybrid procedures with supra-aortic vessels debranching methods seem in the present days not only to become more and more popular, but also to be considered by some surgeons as a good alternative to the traditional anatomical replacement of the arch. Is it so? The rationale on which this trend is based might appear appropriate. First, legitimately preserve the patients from very important, painful, risky operations. Second, more importantly, the fact that it had appeared that some severely healed patients were denied surgery and that some lesions for which surgery was resulting in very poor results could be efficiently treated. Third, perform easier and less invasive procedures with reduced mortality and morbidity rates. It is indeed noteworthy that the same arguments in favor of these methods are regularly put in the forefront by its upholders and continuously repeated through the articles or presentations. Let's analyze the accuracy of those reasons. How the patient's risk is assessed and what is a risky patient? This major question is very seldom addressed. The European System for Cardiac Operative Risk Evaluation, Euroscore, or the Society of Thoracic Surgeons score, or any other score, do not appear in most of the published reports. By the way, it is to note that in most articles dealing with this matter, when one of these scores is calculated, it is generally not worse than for patients undergoing conventional surgery, on the one hand, and that the threshold beyond which the patients are considered non-amenable to open surgery is never objectively defined, on the other hand. So, should we infer that the risk estimation is mostly left to the surgeon's appreciation only? Hybrid procedures are generally considered as minimally invasive. It is interesting to observe that many patients who are supposed to be in too bad a condition to undergo conventional surgery have to undergo a median sternotomy, a side bite cross-clamping of the ascending aorta, probably one of the major factors of strokes, the implantation of a vascular prosthesis before the sequential interruption and re-implantation of the brachiocephalic vessels, and ultimately the placement in the arch of an endoprosthesis with all its possible drawbacks and complications. This, for example, was the case in almost 50% of the patients of the meta-analysis by Coulias and colleagues. Is then such a procedure really less invasive and more appropriate than a straightforward conventional replacement of the aortic arch? Hybrid debranching procedures have the reputation of being surgically easier. This is obviously true if we consider the simple patients requiring only one or two subclavian carotid or carotido-carotid bypasses. But as soon as real complex aortic arch lesions are concerned, it is somewhat difficult to see any simpler surgery than the conventional one. Indeed, the thorax has to be opened, the supraaortic vessels dissected free and controlled. If the ascending aorta or the aortic valve or both are not to be replaced. Again, an end-to-side anastomosis or a bi- or trifurcated graft has to be carried out. And if the ascending aorta has to be replaced, then cardiopulmonary bypass is necessary, sometimes associated with hypothermia, and eventually some circulatory arrest before re-implanting sequentially all the epi-aortic vessels. And the anastomosis on the distal aortic stump has no reason to be simpler than in conventional surgery, especially if the hybrid procedure is carried out for some acute dissection. Where then is the greater simplicity? This is quite obvious when we analyze, for example, methods such as the Luppier technique described by Esposito, in which a trifurcated graft allowing reimplantation of the debranched supraaortic vessels is industrially implanted on a regular aortic graft, used for replacement of the ascending aorta and hemi or total arch, and providing a good landing zone for immediate or further endoluminal stent grafting of the distal aorta. Let's now consider the results of conventional open repair. During the last 3 decades, many groups have adopted those techniques or some variation of those. A very large number of articles have reported the experiences of many groups, and it would be too difficult and long to analyze this important literature. However, we have chosen to indicate here some important articles summarizing well enough what is generally reported. In 2007, Kazui reported his experience of 472 patients operated on between 1986 and 2006 and who had undergone aortic arch replacement with selective cerebral perfusion, moderate core hypothermia, and distal circulatory arrest during the time of distal repair. Among those, 420 patients underwent total arch replacement. Emergent operations were performed on 138 patients, 29%. The overall in-hospital mortality was 9.3%. In-hospital mortality was 16% in the early series, 1986 to 1996, of 206 patients, and 4.1% in the 266 patients in the late series. The overall postoperative temporary and permanent neurology dysfunction rates were 4.7% and 3.2% in the early series, and 5.9% and 3.8% respectively in the late series. In 2008, Sun and colleagues published an interesting study in which they compared the immediate outcomes of patients operated on for aortic arch replacement with 3 different methods of cerebral protection. A total of 347 patients were operated on. Among those, total arch replacement was performed in 95. Isolated deep hypothermic associated circulatory arrest was used in 26 patients. Retrograde selective perfusion in deep hypothermia and circulatory arrest in 19 patients, and selective antegrade cerebral perfusion in moderate hypothermia and distal circulatory arrest in 50 patients. The mortality rate for total arch replacement has declined from 34.6% with profound hypothermia and circulatory arrest to 21.1% with retrograde cerebral perfusion and to 6% with selective antegrade cerebral perfusion, and for elective cases, from 30% with profound hypothermia and circulatory arrest with retrograde to 14.3% with retrograde cerebral perfusion and 2.7% with selective antegrade cerebral perfusion. The corresponding stroke rates were 19.2% with profound hypothermia and circulatory arrest, 5.3% with retrograde cerebral perfusion, and 6% with selective antegrade cerebral perfusion. In 2013, Iba and colleagues published their very large experience of conventional total replacement of the arch. From 2001 to 2011, 1,007 patients underwent open arch repair with selective cerebral perfusion, through the right axillary artery and hypothermic circulatory arrest. Of those 1,007 patients, 73% underwent total arch replacement and 26% emergent surgery for aneurysm rupture or acute aortic dissection. The early mortality was 4.7%. Permanent and temporary neurologic dysfunction occurred in 3.5% and 6.7% respectively. No spinal cord injury occurred. The cumulative survival rate was 80.4% and 71.2% at 5 and 8 years respectively. Freedom from reoperation related to the initial arch repair was 90% and 96.9% at 5 and 8 years respectively. The same year, Okita and co-workers published a large experience of 423 consecutive patients operated on from January 2002 to May 2012 and who underwent total arch replacement using integrated selective cerebral perfusion. Acute aortic dissection was present in 19% of the patients. Emergency urgent surgery was required in 135 patients, 31.5%. The overall hospital mortality was 4.5%, 9.6% in emergency surgery cases, and 2.1% in elective cases. Permanent neurologic deficits occurred in 3.3% patients. Survival at 5 and 10 years was 80% and 71% respectively. Allow me to show our experience extending over almost 30 years. Recently, we have reviewed our experience with all total arch replacement performed by our group between April 1986 and November 2011. Those are unpublished data so far. 252 patients, aged 22 to 83 years, were operated on for aneurysm, chronic dissection, acute dissection. 72 procedures were performed in emergency and 26% were redo operations. The overall hospital mortality was 15.7%, with a mortality rate of 10% in elective and 22% in emergency procedures. Cerebral protection was carried out through selective integral perfusion according to our technique of cold cerebroplegia in 2013 patients and according to Kazui's technique in 39 patients. The rates of lethal neurologic injury was 5.1%, 9.8% in emergency case, 3.3% in elective cases. Of course, one may think that those results are not particularly outstanding, but we should remember that this experience started in 1986 and includes a large number of emergencies. Anyhow, despite their extent in time, those results appear to be in line with some much more recent hybrid experiences. If we indeed observe the last period of this experience in which the Kazui technique of cerebral protection was used, and that included patients of various severity, the results were rather satisfactory. Indeed, in the 39 patients operated on, the hospital mortality rate was 5.2%, and the rate of severe neurologic injury was also 5.2%. It is probably doubtful that any hybrid technique would have resulted in superior outcomes. Let's consider the results of the hybrid methods. If we look at the results obtained by some important groups, we may observe that the results do not appear as superior to those obtained generally with the conventional technique, and that the rate of neurologic complications, either cerebral or spinal, seems somewhat worrisome. In 2004, Xiani and colleagues published their initial experience of 5 patients operated on with the technique for debranching and transposition of the 3 supraaortic vessels. All patients recovered uneventfully without any signs of transient or permanent neurologic injury after the autologous sequential transposition procedure of the arch vessels. In 2012, the same author published the experience of 5 European and North American centers. From 2003 to 2011, 66 patients presenting with pathologic conditions affecting the aortic arch were treated. Hospital mortality was 9%. Retrograde type A dissection was observed in 3% of patients. The end-leak rate was 0%. Stroke was seen in 5% of patients. Permanent paraplegia was observed in 3%. Median follow-up was 25 months. 5-year survival was 72%. In 2013, Bavaria and colleagues reported on the results of 47 patients who underwent extensive hybrid arch repair with either antegrade or retrograde stent grafting of the aortic arch. The hospital mortality was 8%, with a stroke and paraplegia rate of 8% and 5.5% respectively. There were no endoleaks noted, and the aortic reintervention rate was 3% over a median follow-up of 30 months. In the same year, Derango and colleagues published a series of 104 consecutive patients with elective debranching. The 30-day death, stroke, and spinal ischemia rates were 5.7%, 3.8%, and 2.9% respectively. There were, however, 4 retrograde dissections, 2 of which were fatal. At 1, 3, and 5 years, the survival rates were 89%, 83%, and 71%. In 2013, Anderson and colleagues published their experience of 87 patients who underwent hybrid procedures for various types. The in-hospital mortality rate was 8.3%. However, 30-day mortality increased to 28%. 30-day mortality was 29.6% for patients with native zone 0 proximal landing zone, compared to 9.5% for patients with Dacron zone 0 proximal landing zone. The 30-day rates of stroke and permanent paraplegia or paraparesis were 4.2% and 0. Retrograde type A dissection occurred in 3 patients for an overall rate of 11%, when including only patients with native ascending aorta who were at risk for this complication. Over a mean follow-up period of 28 months, 13% of patients required reintervention for endoleak. A few meta-analyses were carried out and published in order to benchmark this innovative approach. This is the case with the large study published in 2010 by Koulias and co-workers. All studies and case reports involving hybrid aortic arch procedures listed through May 2008 were reviewed. Endpoints were 30-day mortality, stroke, paraplegia, and endoleak rates. A total of 15 studies with 463 patients were included in the meta-analysis. Overall 30-day mortality was 8.3%, stroke was 4.4%, and paraplegia was 3.9%, and endoleak rate was 9.2%. It is noteworthy that, as in most publications dealing with this topic, the mean follow-up was very short and did not allow having any idea of the long-term outcome of those techniques. Similarly, Cao and co-workers published in 2012 a large meta-analysis of the literature concerning the results of the hybrid procedures for treatment of the aortic arch diseases. Studies involving hybrid aortic arch procedure were systematically searched and reviewed. Endpoints were periprocedural mortality, stroke, and spinal cord ischemia. A total of 50 studies, including 1,886 patients, were included. Pooled hospital mortality rate was 10.8%. Pooled perioperative stroke rate, regardless of severity, was 6.9%, and spinal cord ischemia, including permanent and transitory events, pooled rate was 6.8%. In cases of aortic dissection, perioperative mortality, stroke, and spinal cord ischemia rates were 9.8%, 4.3%, and 5.8% respectively. In 2013, Moulakakis and co-workers have identified all articles published up to December 2012 that describe hybrid aortic arch repair with intrathoracic supra-aortic branch revascularization and subsequent stent graft deployment. Eligible studies were divided into two groups. Group 1 included studies on the aortic arch debranching procedure, and Group 2 included studies that reported aortic arch replacement and an elephant trunk technique, either frozen or not. Separate meta-analyses were conducted in order to assess technical success, stroke, spinal cord ischemia, renal failure requiring dialysis, and cardiac and pulmonary complications rate, as well as 30-day in-hospital mortality. As we can see, despite the fact that many more patients were operated on electively in the hybrid procedures group, the mortality and neurological complications rates were higher and the overall outcomes obviously not better than in the conventional open repair group. In 2013, Iba and colleagues published a comparative study of 143 patients who had undergone a conventional arch replacement with 50 patients who had undergone a hybrid procedure between 2008 and 2013. The hospital mortality rates were 3 and 2% respectively. The rate of cerebral injury was 3% in the open repair group and 6% in the hybrid group. Lead reintervention for the previously repaired aortic arch segment was required for 1 patient in the conventional group and 5 patients in the hybrid group. Recently, Provenza and co-workers published a comparative study of Zone 0 hybrid arch exclusion versus traditional open repair. They performed a multivariate analysis of 319 consecutive patients who underwent total aortic arch replacement in the past 8.5 years, and a subgroup analysis of 25 propensities matched pairs. A total of 274 patients had traditional open repair, and 45 patients had hybrid Zone 0 total arch exclusion. Operative mortality was 11.1% in the hybrid group and 10.2% in the traditional group. 5.9% of the patients had permanent stroke, 5.5% in traditional group versus 8.9% in the hybrid group, and 2 patients, both traditional, had permanent paraplegia. During a median follow-up of 4.5 years, survival was 78.7% with no intergroup difference. In 2016, Tokuda and co-workers published a comparative study of the patients who underwent either hybrid debranching repair or conventional open arch replacement between 2002 and 2014. Of 364 patients, 58 received isolated hybrid arch repair with median sternotomy. 124 patients received isolated conventional open repair. The mortality rates, 3.4% in the hybrid group versus 0% in the conventional open group, were similar about. The rates of strokes were 17% in the hybrid group and 12% in the open repair group. The rates of spinal cord injury were 1.7% and 0.8% respectively. There was no apparent superiority of hybrid repair with respect to patient recovery. The mean follow-up duration was 52.5 months, during which the rate of freedom from aortic events in the hybrid and open arch repair groups was 79 and 99% at 24 months respectively. Similarly, Cazave and colleagues published recently their comparative experience of 46 patients operated on for exclusive aortic arch aneurysm involving Zone 0 or Zone 1. 25 patients underwent a conventional open procedure, and 21 patients underwent a type 1 hybrid debranching procedure. The incidence of in-hospital mortality was similar at 20% for open surgery and 19% for hybrid procedures. The incidence of permanent cerebral neurological deficit was comparable at 7.4% for open surgery and 21.1% for hybrid procedure. Median survival was 109.5 months for open surgery and 56.3 months for hybrid procedures. Freedom from all-cause mortality was 78, 63, 63, and 57 at 1, 3, 5, and 7 years, respectively, in the open surgical group. Freedom from all-cause mortality was 74, 55, 46, and 28% at 1, 3, 5, and 7 years, respectively, in the hybrid group. Late vascular complications. This is a very rarely found information in the literature. Most authors report the endograft complications and, in particular, the rate of endoleaks, but very seldom the actual vascular problems. Yet, it is to be inferred that with so many Dacron grafts and anastomosis, a certain number of kinking, stenosis, compression are likely to be more frequent than acknowledged. I have found only one paper in which those problems were addressed, and the rate is not so reduced, considering that the mean follow-up was short enough. So, when looking at the results, there is no doubt that anatomically, physiologically, and aesthetically, the conventional open repair seems more appropriate and leading to better outcomes than the debranching techniques. That in some instances may put the patient at risk of cerebral flow disturbances, late aortic complications such as endoleaks or retrograde dissection, and the necessity for a concerning rate of late reintervention or redo surgical procedures. So, we come to our conclusion. Aortic heart surgery must be kept simple. Conventional open repair can be carried out in the great majority of patients. The hybrid techniques are often as invasive and risky as conventional ones. The completion in many cases may be difficult. So far, considering the rates of hospital mortality and neurologic incidence, it is not obviously demonstrated that their immediate results are better than the ones obtained with conventional repair. The late and very late results are still not clearly known and analyzed, and it seems that the rates of late reinterventions or redo procedures is rather concerning. Therefore, we may say that presently the conventional techniques of open repair remains the gold standard of aortic arch surgery. Thank you.